Let's play the hernia game. Let's see how many different types of hernias we can think about. So I'm going to just go across the room. So
indirect.
Okay, so indirect what?
Inguinal.
Okay, so indirect inguinal hernia. I'll take it.
Direct.
Okay. Smart move. Direct inguinal hernia. Okay. All right.
Femoral.
Oh, that's a good one. Okay. Femoral hernia. Oh, good one. Okay. Hiatal hernia. Nice.
Okay.
Umbilical hernia.
This is getting tougher.
It's going to get harder as we go. We could keep.
Like, what's it called? Spigelian?
Okay, good. Spigelian hernia.
Can I phone a friend?
If you don't know, we'll go to the next.
Uncle herniation, like the head.
Uncle herniation. That's not the hernias that we're talking about. That's the brain.
That's the only ones I can think of.
But that is a herniation, not a hernia. Here, well, let's go back then. What's the definition of a hernia? What does that mean?
Like a protrusion.
Okay, protrusion.
I don't know.
Yeah,
Let's get more doctory with it.
like an object that's protruding through a substance that's a hole that it's not supposed to be. protruding
Okay.
through.
What?
Something in
Where's
a
the
place where
hole
it's not supposed
typically,
to
or
be.
what layer is the defect in?
Fascia.
Fascia. Good. So the hernia is a fascial defect. The fascia is the strength layer, and predominantly right now we're talking about the abdominal wall and the pelvis, essentially. Okay. So there's a fascial defect where something is protruding through it, and that could be omentum, which could be like fat, which isn't as scary, or it could be what, which is like what we're always concerned about. Bowel, right? So there's a defect somewhere. Call this the umbilicus, okay? Umbilical hernia, right here, super common, right? And the issue is a loop of bowel can get in there. So then this hernia can be what if I can push it back in? Reducible, not so scary, but needs to be fixed because we don't want it to then get, so there's reducible, or what if it's stuck? Not yet. It's incarcerated. It's in jail. It's incarcerated. Okay. Then the blood supply becomes compromised and it becomes, so strangulated is the worst of all this situation. Okay. That is why we fix hernias. Okay. Because we don't want this reducible hernia to become incarcerated and then strangulated. Now you have necrotic bowel. It perforates. You die. Okay. Very bad. Anybody else got more?
Is there a name for the hernia like after pregnancy where your bowels can protrude through the diastasis recti? Could that be
So diastasis recti is actually not a hernia. That is not a hernia. A diastasis is not a true fascial defect. It's a laxity in the fascia. But what if a pregnant woman had a C-section? What could she get? That's a type of an incisional hernia. Okay, very common. After surgery, always a risk anytime we make a hole in the fascia. Now the fascia is weak. Can get a hernia. What else?
epigastric hernia?
Okay, epigastric. There's another term for that too that falls into this same category. Ventral.
Oh, ventral.
Okay, epigastric, ventral. And I'm really going to confuse you guys in a second, but that's okay. I like to do that. There's another one that's common.
Bactolec or something?
Oh, what the hell is that? I forget.
I feel
That
like
is a
that's
thing.
Genital one.
Bactolec. Yeah, that's a hernia.
And then there's Morgagni. I think those
Okay.
are the genital ones. It's a diaphragm.
Morgagni. Yeah, you're right. I think it has to do with the diaphragm. Yes, it does have to do with the diaphragm.
But, okay, there's another one that's
There's another one that's common that goes with the Spigelian, and it's if half of the bowel becomes ischemic. It's typical in a Spigelian. Starts with an R. Richter's hernia. Yeah, Richter's hernia. There was another one that just came to mind for me. What if I have a defect in the mesentery? So say somebody had a gastric bypass back in the day, and they did a retrocolic anastomosis, Okay, so they made a hole in the mesentery of the transverse colon, and they pulled the J portion up through that for a Roux-en-Y. Now you have a defect in the mesentery. You can get a specific type of hernia. There's a specific name for that hernia, and then it's also considered a more generalized type.
Isn't it just internal?
So that is considered very good. An internal hernia, okay? Internal hernia, and that particular hernia that I just described is called a Peterson's defect or Peterson's hernia. But the idea is what's called an internal hernia. That's why when you do a bowel resection, you have to close the mesenteric defect. Because if you leave it open, something can sneak in there, and you literally get this, but inside the abdomen.
Would a diaphragmatic hernia, is that different than hiatal?
So yes, because you could have a diaphragmatic hernia is a big problem in a newborn, huge problem. But the only time we really see a diaphragmatic hernia is in trauma, okay? But a hiatal hernia is different because it's at the crura, the crux, where the esophagus comes through the hiatus, right? So they are two different things. So I would call like a hiatal hernia and a diaphragm hernia or a diaphragmatic hernia two different things. Does that make sense? Internal hernia, Richter's hernia. Now I'm sure there's more. I'm trying to think now. Now I'm almost at a dead end street here.
Is there a dorsal hernia?
Oh, what's it called if you have both of these?
Oh, I didn't even know this was a thing.
Yeah. So it's called a pantaloon. And I think of it as like wearing pants and like you have both. Okay? So, all right, we started with Ryan, right? Over here. All right? Okay, describe to me what are the anatomic things about an indirect hernia?
Well, it enters through the deep inguinal ring.
Okay.
Exits the superficial.
So what's the structure that's very important with these two?
The epigastric
Yeah,
vessels.
the inferior epigastrix, okay? So our relationship to the inferior epigastrix is what delineates the difference between these two. So indirect is what?
I think it's lateral.
It's lateral, okay? And indirect, it enters or goes in, it can go into the scrotum. So it's an ilioinguinal hernia, scrotal hernia. Indirect, lateral to the vessels. Direct is medial to the vessels. The nice thing about robotic or a TAP, what does TAP stands for?
Transabdominal preperitoneal.
Yeah, transabdominal preperitoneal. Is you fix, which hernias can I fix with a TAP out of these?
Indirect, direct,
These three, which is really cool. So that's the nice thing in a difference between an open inguinal hernia repair versus a TAP, laparoscopic or robotic assisted TAP, transabdominal preperitoneal, is you literally tackle all three of these from the exact same procedure, exact same approach, which is super cool. Versus open, because femoral hernias are tricky to repair open. You got to get a little creative with your either tissue repair or mesh repair. So that's where I was going to go next with this. But let's keep talking about these. So we got the big distinguishing factor of this femoral, like we said, femoral hernia.
Yeah.
There's a triangle down there. Anyone know what that triangle is called? Hasselbalch's triangle. Good job. This we talked about. So another approach here. So now what's the type of hernia you get with a hiatal hernia?
And your stomach can go up.
Okay, so the stomach can go up into the chest, right? Okay. And then there's the bowel. So there's a classification system of these. So what is that?
I mean, there's different types, right? Is that what you're talking about?
Yeah.
Like sliding.
Yeah. Now we're talking. Because these are what? Paraesophageal hernias.
Yeah.
Okay.
Sliding hernia.
I forget what
Yeah,
the
I
terms
don't
are.
Okay, so there's sliding. It all depends about where the GE junction is.
Oh.
So sliding, the GE junction comes up into the chest, type 1. Type 2 is a true paraesophageal where the GE junction is down, but the stomach comes up. And then the stomach can flip or volvulize in two different axes, organoaxial and mesentericoaxial. Anybody ever heard of this? No? Okay, now we're getting super technical. So the axis of how the stomach for a paraesophageal hernia flips up into the chest matters, because it really, when you see a CT with a paraesophageal hernia, I'm concerned, again, always about this, because hiatal hernias are typically chronic. They don't just like happen like quickly. It's a chronic issue. But depending on if it's mesenterico-axial or organoaxial, so again, organoaxial is the stomach is like this, and it's volvulizing on its axis of the organ versus on the axis of the mesentery, mesenterico-axial versus organoaxial, okay? Then there's a type 3, which is what? So it's a combination. So you have sliding and paraesophageal. And then type 4 is kind of what we were just saying, is when anything else is up there with it. I've seen everything up there. I've seen colon up there. I've seen pancreas up there. I've seen it all, okay? So that's hiatal hernias in a very quick nutshell. And those are important distinguishing factors for the different types. Umbilical, pretty straightforward. If I had a large 5-centimeter umbilical hernia versus a 1-centimeter umbilical hernia, what are my options here for repair? Talk to me.
We still do laparoscopic, right? With that?
We could do laparoscopic or open, always. But what's the difference here with size?
Does one use a mesh or one?
Exactly. The question is, do I need a mesh or not? Do I need something to reinforce this? And I pretty much 99.9% of the time use now a bioabsorbable mesh made out of what's called poly-4 hydroxybutyrate, or Phasix. And this is nice because it gives strength, but it's reabsorbed. It's made of butyrate. It literally eventually turns into CO2 and water. It's a beautiful product. That's what I use to reinforce my repairs. So this one you could theoretically, a centimeter, you could theoretically repair primarily versus a 5-centimeter defect. Now we're talking bigger. You want some tissue reinforcement with a mesh, which was called back in the day like a Liechtenstein repair. Primary tissue repair back in the day, we would call that a Bassini repair, okay? Umbilical spigelians are tricky, and flank is the other thing I could add here. Those get tricky. Incisional is over an incision, like we just said. That's when you really want to think about using a mesh reinforcement. You don't want to repair an incisional hernia primarily. Kind of stupid, right? Because it failed the first time. Epigastric or ventral are up here, Richter's, and internal. Internal, it's being its totally own thing inside the abdomen. So the CPT codes changed for all of these, though, when I bill. And they're all classified as anterior abdominal wall hernias. This is above the scope of your guys' pay grade, but it's good to just know things now. So they all fall under anterior abdominal wall hernias, and you classify them as either reducible or incarcerated strangulated. Those are each their own category. And then they simply go by size. So less than 3 centimeters is one category, 3 to 10 is a separate category, and greater than 10 is another category. So if you look to bill for an umbilical hernia repair, there is no such thing anymore as an umbilical hernia repair in the billing world. There's only an anterior abdominal wall hernia, and if it's 5, it would fall into that 3 to 10, reducible or incarcerated strangulated. So that's like the billing algorithm. Changed like 2 years ago-ish. It was funny because like one day after New Year's, I was like billing an umbilical hernia, and I was like, where'd the code go? No one tells you these things, unfortunately. I think I'm the only attending that teaches you guys about billing. I was saying that today. Hernias.